Well, good morning and welcome to COVID-19 Talks with local health authorities. Joining us is Dr. Erica Brown, the Health Authority for Harris County, and we also have Dr. David Purse, the Houston Health Authority for the City of Houston. Special thanks to past President Kathy Finnegar of the Rotary Club of Houston, Morgan Ash, our producer. I am Jaeana White, the Deputy Health Authority of the Houston Health Department, sitting in for Director Stephen Williams. So let's start off with our first question. The FDA gave emergency use authorization to a second booster for those over 50, and the CDC has now approved that as well. So here's a few separate questions on this topic. A study in Israel shows seniors who received a second booster of Pfizer had a 78% lower mortality rate from the disease than those who got only one. Has any U.S. study been reported?
So I'll take the first question. Thus far, we don't have any U.S. studies that have been reported. The FDA did cite the data from the preliminary study in Israel that examined adults 60 years of age and older. And that I am sure that that was part of what was used to make the decision to offer the booster to those 50 years of age and older.
Awesome, thank you. If there's no increase in cases, should we wait for a few months to get a shot so it will last longer?
Yeah, so this is a good question, and I imagine a lot of people are asking themselves. The conundrum you find yourself in is that once you get the shot, it takes 2 weeks for it to have its impact. And with our, with Omicron, we saw that it exploded so quickly that 2 weeks winds up being a really long time, and we are anticipating that BA2, the also an Omicron variant, is probably, if it comes to Houston, it will probably also rise equally fast. So you take a chance if you want to wait until we have a rise, because you may be too late. Remember, once you get your shot, your body doesn't really get the benefit from that shot for 2 more weeks afterwards. So that's a difficult question. I'm not going to wait, but that is the chance that you take. Now, the other hand is that once you get it, the impact lasts for months and months. And here's the other thing to keep in mind is we talk a lot about antibody response, but there's also this long-term memory development that occurs with the memory cells in your immune system every time you get it too. So a lot to consider, but I'm not going to wait.
Awesome, well, thank you. So someone's asking, and so you kind of framed it a little bit, they're probably positioning this question to think about the flu and that a flu shot is every season. So someone's asking, like the typical time we get the flu and the flu shot, what month would be optimal to receive your COVID vaccine?
So I think Dr. Purse did frame it perfectly. Right now, we don't have data that says, here is the season for COVID. As you know, COVID has just been year round. So the answer is really, as soon as you can get the booster, it probably is best for you to do so. As the data comes out longer term and we examine what happened, we may have some different recommendations. But for now, COVID is not a seasonal virus like the flu. So it's recommended to go ahead and get the booster when you can.
So going along with that booster discussion, if you had received one manufacturer versus another manufacturer, and now you're up to get your 4th dose, what's your thought about mixing and matching with vaccine as far as manufacturer?
So the data on this is really pretty clear, is that you can mix from one manufacturer to the next and still get really good results. So which one is the best one for you? It's the one that you can get quickest.
Can I add to that for just a second, though? Specifically, though, the CDC has said for Janssen, you should mix and match. You should get, and Janssen is the Johnson & Johnson version. You should get either a Moderna or a Pfizer booster.
Okay. So do you think as the protection from the booster shot will wane over time and we'll see that we'll have another surge from that?
I think it really, We may see some BA2, for instance, we may see a surge from that. I think, though, that the key is not whether we'll continue to see surges, right? Because technically flu season, if we want to use that analysis again, is a surge. Every year there's a surge with flu season. I think the question is really, have we gotten enough immunity across our communities, across our country, across the world, that these surges are have minimal effect? So again, going back to making sure we're doing all we can do to protect ourselves.
So what's the latest on kids getting vaccinated under 5? Do you guys think it'll happen before school starts in the fall?
That's a great question. Well, let's hope so. The manufacturers are working really, really hard, and Pfizer, as you know, did initially petition the FDA for approval, and then they withdrew that when it looked like the data wasn't going to be strong enough. Moderna is also working, and so it's March now. So in the development of vaccines with this new technology, September is a long ways off in many regards. So I'm hoping that we'll see something, but and I would anticipate that Moderna probably has something. In fact, I think they came out this last week and said that they've got something that they're planning on showing to the FDA pretty quickly here. So I think it's a safe bet that we'll probably have something by fall.
So dealing with transmission, someone asked, in this week's TMC, today's email, the R0 rate went to 2.53, which signifies the virus is spreading. What are your thoughts?
I think that, again, with the BA2 variant and with the Omicron variant, we are seeing increases in virus. However, what is important to note is that we're not seeing increases in hospitalizations and increases in ICU bed utilization. Again, there may be times where, depending on, given the questions that were asked before about the variants, depending on the variant, we may see a rise, but that may not necessarily translate into severe illness.
Understood.
Can I join in on that? So the other thing that is, and this is one of my sort of pet things to whine about, but the value RT, R0, R little 0 is a characteristic of a virus or a bacteria, of a pathogen. And really what it means is that in a otherwise unprotected community, if one person comes in there and they're infected with this virus, in this case, how many more people are they likely to infect? And so we see with the seasonal flu, that number is like 1.1. And this is why every year we get the flu and it goes up, and then it kind of, at the end, obviously the flu goes away because the RT means that for any specific event, that number changes, right? But the R0 is a characteristic of the virus. The RT is what is happening in the community at that time. And I think that gets lost a lot. So some of our most contagious viruses, like measles, has an R0 somewhere, depending on where you read, somewhere between 10 and 15. And I've seen numbers even higher than that. But it also kind of goes to what is the equation that's used. And so with this recent jump in the RT, it's using real-time, data from what's going on in our community. And we had this recent data dump that probably impacted that. So we got to be careful when we look at it. I'm not a big fan of RT because I think it's misunderstood, number one, and number two, the equation for it is very complicated, and therefore it is susceptible to aberrations and other data sources.
Well, I'm glad you brought up the issue about the data. So on March 21st, Houston cases were 189, and then the next day, 3,280. And then by March 23rd, we saw 9,562. So was this a massive spike or a local reporting error?
Yeah, so this was a reporting error, but it wasn't local. Actually, it was kind of local. It turns out that one of the testing vendors did what we call a data dump. They provided the state and the CDC data going back to the beginning of the year, all in one couple of days. And so the problem was, going back to them, why were they not updating that data, regularly in a timely basis? And I don't know the answer as to why they didn't do it, but that's what happened. And in the beginning, we saw this was a fairly common and frequent problem as testing vendors were getting up and getting their data systems up and going and reporting between one agency and the next. It was very common, 18 months, 2 years ago. It's been far less common now, but it was a huge data dump, and we call it a data dump, but data transfer is probably the more proper term. But it was the dates of those tests went back to January of last year, but they all hit the system over a short couple of days, and that's what made it look like all of a sudden we had this huge number of cases, because everybody was looking at the day that it was reported into the system, not the date of when the test was actually taken. So
that's so helpful. So then what stats, someone asked, so what stats should we be looking for regarding putting our mask back on?
Community spread is for sure one of the things we should be looking at. So for our community, for Harris County and for Houston, we still are using a color system. So when we see those colors change and we go back into high risk, which is for the county, is based on hospitalizations, ICU beds, the number of infections rising in a certain time period, that would indicate that we need to put our masks back on. But certainly, as we continue to see variants, and some of those variants, right, Omicron and BA2, and depending on your immunization status, they are highly transmissible. They may not be cause severe illness for most, but they're highly transmissible. So at the end of the day, if you feel that you are at risk, regardless of what the numbers say, we are still in a pandemic and you should be wearing a mask.
So do you think shutting down a major city like Shanghai, this is another consideration that the person's asking, is worth it? So
great question, very complicated answer. When we first had COVID coming in here in the United States, shutting down and all what that means is a really highly effective way of slowing down the virus. And remember, we talked about flattening the curve, right? So the number of people, if you flatten the curve in the purest sense, what that means is in the end, the same number of people will probably wind up getting sick, but they won't all get sick at the same time. And so your hospitals can then handle it for the most critically ill folks. You flatten the curve, right? And those are highly effective. I want to remind folks that when we had our very first cases of COVID here in the greater Houston area, it was the folks that were on the Egyptian river cruise who traveled and came back, and they were all infected while they were on that Egyptian river cruise. We were able to, by doing what we usually do with isolation and quarantine, we stopped that spread. There was no further spread. And there were 12 people who came into our community who were infected, and we stopped it by basically their lives, shutting down their lives. So the same concept on a community scale, it's almost impossible to completely stop it, but you can flatten the curve. Now, jump forward to today. In Shanghai, one of the largest cities in the world with many, many millions of people in it, they in fact can't shut down the entire city at once. They're shutting down one half for a week, and then they're going to shut down the other half for a week. And over the last 2 years, China has done a lot of this, and it has been really amazingly effective in their country. Their reports of total number of deaths per capita or per 100,000 and illnesses are much lower than a lot of other countries. But here's where I think that in this case, it may not work for them. We'll have to wait and see, and I applaud them making the effort. But two things. One is because Omicron spread so fast and so easily, even shutting down may not work this time. Whereas it worked better with the original Wuhan strain, and then Alpha and Delta. It was effective because it didn't spread. It spread very fast, but not as fast as Omicron, which spreads, almost crazy fast, right? So I don't know that it's worked. But here's the other important thing. China suffered from the same problem that we have here in the United States, that there's a lot of people who have been hesitant to get vaccinated. And so had China been as aggressive as they were and slowed down the virus when it was Alpha and Delta and the Wuhan variant, and then during the window of opportunity to get their population vaccinated, they probably wouldn't be having a problem today. But now they're actually potentially in a worse situation because they were so effective before that they don't have the natural immunity from previous infection because they never had those previous infections. And on top of that, they've got vaccine hesitancy on the part of a lot of folks. So this may be a setup for a really catastrophic problem for them. We'll have to wait and see. But long answer to a pretty straightforward question. Sorry.
No, but actually, so then the next question, it leads right into the next question with regards to the BA2. So then what does BA2 look like for our community? And then what are some of the considerations that you might have just alluded to with regards to getting vaccinated for what it might look like for our community? And Dr. Peirce, I don't know if you might want to also include, as well as Dr. Brown, but their consideration on the wastewater. So this is a BA2 question.
Should you want me to continue or do you want me
Go
to?
ahead, go ahead.
So, so I think that here in the greater Houston area, BA2 is here. We've been looking for it in the wastewater, but there was in such small amounts that the team said, you know, we think this is BA2, but it's so small a signal, we're a little hesitant to actually say that. Now, this last week, we actually had enough that they are now confident saying, yes, this is in fact BA2. And in fact, our partners at Methodist have shown that they sequence every patient, and they had been running 2 to 5% of their tests that were positive were BA2, and it had been pretty steady for many weeks. And then this last week, it went up to 25%. At the same time, we saw the signal in the wastewater go up as well. And so now the folks who do the wastewater testing are confident that what they thought they were looking at that might have been BA2 going back many months, in fact was. They were right all along. They just didn't want to say so because the signal was so small because there's so little of it in our community. So BA2 is here. It does appear to be rising. Keep in mind that we're overall in our community, the value of infection is pretty low. And so we see these little blips going up. We don't need to overreact, but it won't surprise me the least if this is the beginning of the next wave. We've seen this wave of BA2 go across the rest of the nation. There's no reason why it won't occur here in Houston. It's just kind of like when. This might be the beginning. It might not. I think we need to wait another week to see what happens to have a better insight as to what's coming. But the wastewater, it went from 18%, which is the lowest we've ever had since we started doing this, up to 25%. So they said, wow, it went up from 18 to 25%. Remember, we've been as high as 1,500%. So 18 to 25 is a tiny little increase. Let's not lose our cool here, and let's pay attention and see what happens next week.
No, Dr. Brown, did you want to add anything about the BA2? Okay.
Thank you.
So the CDC removed 25% of reported deaths for those under 18 years of age and said it was a coding error. How can that happen? The high percentage is outside of any margin of error.
So again, this is a simple question, but a very complicated answer to take some of Dr. Peirce's language. When we're reviewing deaths, and I mean we as in the medical community, epidemiologists, physicians, those with the CDC, World Health Organization, et cetera, if COVID in any way was a contributing factor, sometimes that is listed on the death certificate. As well as because we've been so vigilant in testing, if it was something that was picked up, even if that's not why the patient came to the hospital, sometimes that's also coded on the death certificate. So when we do a deeper analysis of what actually happened with that patient, sometimes we find that it perhaps was maybe not a contributing factor. So that's one thing. The second thing is that the CDC officially reduced its report and removed 400 pediatric deaths. And so that's a change in 24%, okay, and over 7,200 adult deaths. So part of that, again, is just the way in which it's reported. Pediatrics were mixed into adult deaths. And so obviously there's a difference there, right? So that's a different bucket. And the error was cited in the algorithm and it affected 26 states. Okay, so there's two things happening here. Again, when we review, the medical community reviews, sometimes we will find that this perhaps really, it was not necessarily due to COVID, that perhaps was an incidental finding. Then again, there's a second thing that happened specifically with pediatric deaths where they were coded with the adult deaths and they were just split out. Okay.
Thank you. So let's see, we're going to treatment. So states are expected to see a 30% drop in monoclonal antibody allotments. Any thoughts about your concerns for treatment in the community?
So I'm not sure what if the person who wrote the question is referring to the sotrovimab, which is being withdrawn because it doesn't work against BA2. And so it's not being shipped anymore. And if that's the origin of the question, that's the explanation, is that we found out that BA2 doesn't respond to that medication. So they've stopped sending it. Because here's one thing we don't want to do is you certainly don't want to give any false hope and have the, the physicians and other caregivers prescribing a medication because gee whiz, maybe it'll work when in fact we know that it's not going to work. So it's been removed from the market because it won't work against BA2. And so I suspect that that's where this question is coming from. And that's why there's the big drop in the treatment.
Now there's a March In question about the March In rights campaign. The government steps in and licenses certain patent rights to another manufacturer. One is Paxlovid. Any thoughts about that?
Pfizer projects it can manufacture around 100 million doses of Paxlovid this year. So it's not expected to remain scarce, okay? An emergency intervention in existing U.S. patent laws may be unnecessary. So we'll have to wait and see how this all turns out, okay? So Pfizer and the medicines patent pool signed an agreement to allow 35 companies to produce a generic version of Paxlovid. So it's now making the drug available to 95 low and middle income countries as well. So I think this is a wait and see.
Oh, good news. So then when you look at some of the outcomes of having gotten COVID, the question is long-term effects of COVID now show the brain shrinkage, cardiovascular risk, and diabetes. Do you think that's true? Are there any other issues around long COVID you want to talk about?
Well, one of the things about SARS-CoV-2, this virus, first of all, there are many things about this virus that make it unique, but one of them is that it, unlike most viruses, seems to be able to attack any organ system in your body. We've seen skin complications, vision complications, lung complications, cardiovascular complications, intestinal complications, neurologic system complications, urologic system complications. There is not any organ system that this virus has not, in some people, impacted, which is unlike rhinovirus and flu, which tend to be, rhinovirus, it's called rhinovirus because it goes to your nose, right? It causes the simple cold symptoms. The flu tends to be more your lungs and upper respiratory. And then we have, other viruses that seem to attack certain organ systems, but this one's different than it can attack any organ system. The other thing that makes it unique is it has this ability to cause permanent damage. Again, in almost any organ system, including your pancreas, and hence this is why we're seeing people who are developing diabetes. So, so yes, it's true. Some people, we're talking about long COVID. Some people seem to have it for months and go away. There are still patients who have had this, and it appears that their problems may in fact be permanent. So it is true, and that's another reason why I personally, I've been boosted. So my chances today of getting sick and requiring hospitalization are really, really small. Am I going to get the fourth booster? Yes. And the reason is I don't want long COVID. I don't want these other further, perhaps even if they're months long and perhaps permanent complications, I do not want to take the risk. My risk of getting a fourth shot, it's not zero, it's tiny. My risk of getting long COVID, should I get infected, is way too high that I'm not comfortable at all with that. I will take whatever risk there is with this fourth shot, I'm taking it because I don't want all these other problems that we're seeing with folks.
Love the
So are you getting the shot, Dr. Purse? You gonna get it?
So I think you answered this. Patients, someone asked if they read MedPage today. Patients with type 2 diabetes have a reduced risk for developing long COVID. Is that true?
There is some data out that suggests that patients with type 2 diabetes may have lower risk. But again, the key word here is there's some data to suggest. Studies need to be completed around that. And it also appears to be dependent on what strain of the virus you are infected with. So we really don't have much data on that.
They ask, for those having COVID, I'm reading there's a 40% increased risk of diabetes even at 1 year. As I'm always at a too high level, but not diabetic, what can I do to eliminate the COVID-related risk?
Get vaccinated, wear a mask.
Understood.
Just don't get infected. Do whatever it's to get infected.
Now we have a Facebook Live question. I want to see if this is just to see if you had any thoughts. They were in a UT antibody study, and over 9 months, our vaccine Moderna antibodies dropped substantially. No one can say what is an optimal antibody number. How often will these boosters be needed? And how safe is it to continue to get the vaccine? Because I know several people who have had COVID more than once and have been sick.
So there are a couple of things to unpack there. First, let's address what I think is the easiest thing. Let's be clear that the vaccine was never meant to prevent people from getting COVID. It is meant to provide people immunity so that they do not get severe illness. And speaking to Dr. Peirce's last statements, long COVID, again, hospitalization, ICU bed hospitalization, and unfortunately death. So we need to be really clear on what the purpose of the vaccine is. It is not meant to prevent illness. Similar to people getting the flu vaccine can still get the flu, but most likely they will not have severe illness associated with the flu. So that's number one. The second thing with related to getting the boosters. Right now, we are still in a fight with vaccine hesitancy to get everybody vaccinated so that we can establish herd immunity, not only in our community and in our country, but across the world. And until we are able to do that, there's still a risk, right? That there's a variant that will sweep our country, will sweep the world again, because we haven't established the appropriate herd immunity. And one of the best ways to do that, again, is to get vaccinated. So I don't think we can answer the best about boosters, about how long each booster will last, although we do have data, which is why they're recommending boosters, right? That there is some waning of immunity at about 6 months or so. Not that you still don't have immunity. Again, going back to what Dr. Peirce said, there's some memory there, right? But the amount of immunity that you have does go down a little bit, and we know that for a fact. And so in order to boost it up until we are able to get immunity across the world, right, there's still a little bit of a risk. So when these boosters come out, it is still highly recommended that we go ahead and get them.
Thank you, Dr. Brown. So our last question, quickly. This person said they learned a new term from their grandkids, mask fish. Not sure if this helps with confidence or destroys it. Your thoughts?
Yeah, so this is a new one on me, and apparently it's a takeoff on the term catfishing. Mm-hmm. So my understanding, now I'm not a teenager, but my understanding, I know, shocker. My understanding is that, when you're an adolescent, we all had, well, maybe not all of us. I'm sure I'm the only one on here today who had problems with acne and, some facial hair growing in when I first started, and other facial things. Well, if you're wearing a mask, your friends at school, they never see any of these goofy things that are going on with your face when you're an adolescent. And so my understanding of this mask fishing is kids who want to continue wearing masks just to hide the challenges of adolescence. That's all I know.
Well, I'll leave it with that last thought. Thank you, Dr. Peirce. Thank you guys for joining us for the COVID-19 talks with local health authorities. With us was Dr. Erica Brown representing Harris County and Dr. Peirce representing the city of Houston. Special thanks to past President Kathy Finnegar of the Rotary Club of Houston. Thank you, producer Morgan Ash. I'm Jaeana White, Deputy Health Authority for the Houston Health Department.